Hello, everyone. Thank you for joining us today for our webcast entitled MACRA, MIPS, and APMs, Participating in the New Quality Payment Program. Today's presenter is Bruce Mackey, Alterum's Regulatory Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. A PDF copy of today's slides can be downloaded right now from your GoToWebinar interface. You will see two versions there, one with full page slides and one with 3 slides per page. To follow along, feel free to download either or both files. We will be keeping everyone muted during today's presentation. If you have a question, please type it into the questions box in your GoToWebinar interface. We will take time at the end of the presentation to answer any questions you have. Because of the large number of attendees for today's webcast, we may not have time to answer all questions. If we do not address yours during today's broadcast, you will receive an answer through email. Also, you will be receiving a link to our YouTube channel and a recording of this webcast in a follow-up email from GoToWebinar tomorrow afternoon. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since Medicare policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. Today, Bruce will start out by providing you with a brief overview of MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. From there, he will take a deeper dive into the Quality Payment Program, the 2 tracks within it, as well as discuss program scoring, incentives, and penalties. Following that, Bruce will spend time discussing what you can and should be doing right now to participate in the program in 2017. Following the presentation, Bruce will take time to answer any questions posed by the attendees. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you everybody for joining us today to discuss the MACRA program, and more specifically the Quality Payment Program within it. Before I begin, I'll just have a slide here with a glossary of acronyms. We like to talk in alphabet soup in healthcare, and if I hit any acronyms you are unfamiliar with, you should be able to find them in this glossary here. All right, we'll begin with just a real high-level view of MACRA. So what is MACRA? It is the Medicare Access and CHIP Reauthorization Act of 2015. It is bipartisan legislation, and yes, that actually can happen with today's Congress. I bring that up really just to point out that if anyone is hoping that the current administration is going to get rid of MACRA or the Quality Payment Program, that is not going to happen. It had tremendous bipartisan support, both sides of the aisle. I think it might have had 8 dissenting votes, I think. And so it had tremendous support. And really, we wouldn't want it to go away. If it goes away, we might get something like the SGR, the Sustainable Growth Rate, back. And we most definitely don't want that. MACRA is a lot more predictable than the SGR was. It's going to increase the number of physicians that are participating in something called alternative payment models, or APMs, which I'll describe in more detail in just a little bit, with those in high quality, efficient practices benefiting financially, and significantly so, in fact. This program does extend the Children's Health Insurance Program, the CHIP program, for an additional 2 years, as the name would suggest. And the main thing it brings to us, introduces us to, is the Quality Payment Program. It is part of this broader shift towards paying for value and quality from CMS. There are some goals that were embedded in this program, and they're really all about shrinking the pool of providers that are being paid under a fee-for-service model to be as small as we can possibly get it. Ultimately, we would like to see the fee-for-service reduced down completely and down to 0. I have somebody saying there's an echo in my audio. Let me see. Yeah, I'm only on the phone, so I don't know where that echo is coming from. I don't know how to get rid of it either. Hopefully no one else is experiencing that. So again, it's all about shrinking that fee-for-service down to be as small as we can possibly get it, hopefully eliminating fee-for-service payments completely in the long run. These goals that are on your screen now, CMS reports they are well on their way to achieving. There's also some strategic goals that have been built into the program as well, such as improving beneficiary outcomes, enhancing the clinician experience, increasing the adoption of advanced APMs, maximizing participation, improving data and information sharing, and ensuring the operational excellence in program implementation. All worthy goals. We'll see over time if the QPP is able to realize these goals. I want to draw your attention to the website down in the lower right-hand corner of this slide, the qpp.cms.gov. CMS has really put together a wonderful, helpful, informative, resource rich website here around the QPP. Everything that I'm discussing today can be found there and more. I'll touch again as we get a little bit deeper into this into another website, our website, the QPP Resource Center for the Midwest. Between those two websites, you should be able to get all information you could possibly need on the QPP. So I want to show you just this conceptual diagram of MACRA. There's a lot of new terms here. And there's a lot of confusion about what they are and what they mean. So at the top, we have MACRA. It's the overarching legislation that everything else is contained within. There were a lot of other regulatory changes embedded within MACRA, a lot of changes. We're not going to touch on any of those regulatory changes. We're focused on the quality payment program here in this presentation. Then we have two paths within. We have the merit-based incentive payment system, or MIPS, and then we have alternative payment models, or APMs. And then under APMs, we have essentially three different types of APMs. We have advanced APMs, which is kind of the gold standard, ultimately where CMS wants the majority of providers to be in. And we also have two other types of APMs. We have MIPS APMs, which I'll explain as we get a little bit deeper, but MIPS APMs essentially bridge the gap between the merit-based incentive payment system and the advanced APMs. And then we have non-MIPS APMs. There are other APMs that don't qualify as a MIPS APM. We refer to those as non-MIPS APMs. So we're going to talk about track one of the quality payment program, the merit-based incentive payment system, next. So what is MIPS? So MIPS combines multiple Medicare Part B programs into a single program. So it takes the Medicare EHR incentive program, the Medicare Meaningful Use program, and I want to pause here and just point out that it is just the Medicare Meaningful Use program that is a part of MIPS. The Medicaid EHR incentive program is still alive and well. It is progressing into stage 3 eventually. It is on track to continue through 2021. There are still significant incentives to be claimed if you have providers that have not claimed all 6 of those incentives. So MIPS and Medicaid Meaningful Use are now parallel programs. You have to attest separately in each one. Participating in one does not give you credit in the other. These are now separate programs that require separate attestations. Okay, so back to MIPS. We have the Medicare EHR incentive program. We have the Physician Quality Reporting System, or PQRS, that's been around for 10, 15 years, I think. We have the Value-Based Payment Modifier. Takes those 3 programs and combines them into MIPS. So within MIPS, we have 4 performance categories that folks are participating in. We have the Quality Performance category, which is formerly the PQRS and the quality side of the Value Modifier program. We have the Cost Performance category, which is the cost side of the Value Modifier program. We have something called Advancing Care Information, or ACI. This is just new terminology for Medicare Meaningful Use. So Meaningful Use is still a component of MIPS. We just don't call it Meaningful Use anymore. Within this program, it is now called Advancing Care Information, or ACI. And then there's a new 4th category that is being added called Improvement Activities. And while this is a new category, the activities within it really are not new. And I'll talk about those in just a bit as well. So who's eligible to participate in MIPS? So for the first 2 years, years 1 and 2, 2017 and 18, the list is pretty limited. There are only 6 provider types that are eligible to participate. We have MDs, DOs, your physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. That's it. Those are the 6 provider types that can participate in MIPS this year and next. We do expect to see additional provider types being added to this. However, this is not finalized yet. So we know that CMS is going to broaden this list of eligible provider types, but it has not been finalized yet. We'll have to stay tuned from additional final rules from CMS as we get closer to year 3 to find out what other provider types it will expand to. We have some information from CMS here, a bunch of more acronyms for you that we believe it will be opened up to. So the interesting thing here is under the PQRS program, a lot of these additional providers were reporting under PQRS, or were potentially required to participate. And now for the first 2 years of MIPS, they are not eligible providers. So some providers, some mid-level and ancillary providers who are potentially participating in PQRS will be kind of taking a step back, and they're not required to participate in this program for years 1 and 2. There's another terminology change here under meaningful use and PQRS. We use the term eligible professional to denote those that were participating in the program. That is now being replaced with eligible clinician or EC. So the other side of the coin then, who's exempt from MIPS participation? There are a few different groups of folks that are exempt from participation. We have first-year Medicare Part B participants. So if this is the first year that a clinician, they just got credentialed to accept Medicare, they're off the hook for MIPS in that first calendar year. But the next calendar year, they are a MIPS provider, assuming they get over the next category, that low volume threshold. So I think this is where we'll see a large group of providers not qualify because they cannot overcome this low volume threshold. That low volume threshold for this year anyway is defined as Medicare allowable billing charges of less than or equal to $30,000 or provides care for 100 or fewer Medicare patients in 1 year. So to opt into the program, if you are going to participate in MIPS, both of these need to be true for you. You have to have more than $30,000 in Medicare Part B allowable charges, and you have to provide care for more than 100 Medicare Part B patients in the measurement year. If either one of those conditions is not true for you, then you are exempt from MIPS. So both have to be true to get in. If either one is not true, you are exempt. And then the third category is certain participants in advanced alternative payment models. And I'll talk about what an advanced alternative payment model is. But if you are a qualifying participant in one of those advanced APMs, then you are also exempt from the MIPS program. So there's a couple of different ways that you can participate as well. We can participate in this program as an individual. So that is each NPI and tax ID combination. So if a provider works for multiple organizations, meaning they work under a separate tax ID, the program sees those as 2 separate entities. So each NPI and tax ID combination will report separately to the MIPS program. So you can participate as an individual. You can also participate as a group. So as a group, it's any 2 or more clinicians who have reassigned their billing rights to a single tax ID number. So you can band together and form a group. The interesting thing about this group participation with relation to the low volume threshold is that low volume threshold does not change. So it stays at that same level of 30,100 patients. So by participating as a group, this is a way that several or a group of low volume ECs can band together and overcome that low volume threshold. You don't multiply that 30,100 by the number of clinicians in the group. It stays the exact same. So you could have 2 clinicians, 5 clinicians, 10 clinicians. You could have a number of clinicians that band together as a group. None of them overcome that low volume threshold on their own. You add their patients and those Medicare Part B allowable charges together, and they can overcome that threshold. If you are in an APM entity, and by APM you can think ACO in this regard. If you're in an ACO, if you're in an alternative payment model such as an ACO, you are in group participation. You are forced into participating at the group level within that alternative payment model, or ACO as it were. So if you participate as a group, then you are assessed across all of the performance categories together. You can't pick and choose and say, I'm going to individually report under the quality category and group report under ACI. You're going to group report under all 4 categories, or you're going to individually report under all 4 categories. So as you're participating in the program, you're working towards this MIPS final score. So that MIPS final score it takes those 4 categories. They're weighted differently. I'll talk about how the weights shake out in this first year. You're building this MIPS final score. It can be anywhere from 0 to 100 points. You want to get as close to 100 as you possibly can. So here's how we're going to use these categories in this first year. CMS has made 2017 a transition year. They're allowing us time to kind of ease into the program, so you don't have to hit the ground running and fully participate across the program, although I certainly suggest that you try. But we have some options here in this transition year. One of the things that they're doing in this first year, and most likely the next year, is we're only going to use 3 of the performance categories. So within that 100-point scale, we see where each of those 100 points comes from, but we're not going to use the cost category. In future years, we will see the cost category used. It is most definitely not going to be used in this first year. It's likely not going to be used next year. We'll wait to see that finalized later this year, but it will be used in future years. And ultimately, the goal with these weights is to eventually have quality and cost be of equal weight at about 30% or 30 points each, with the rest of the points then coming from the other categories. So as part of this transition year, we also have something called Pick Your Pace. So again, CMS is allowing folks some time to kind of transition into this new program, and they've given you 4 different ways to participate. Although the first one isn't participating, and nobody should choose the first one, which is don't participate. That is, that you are not going to add anything, you're not going to provide any data to CMS. So don't do that, please. Nobody should do that. If you choose the don't participate path, you will receive a 4% negative payment adjustment on your Medicare reimbursements in 2019. So don't do that. You should at least do the next one, which is submit something. And honestly, to me, this isn't a good option either. I think everybody should be in the 3rd and 4th option, or should be shooting to be in the 3rd and 4th option. But you can always fall back onto the submit something option. Under this one, under submit something, you are sending a minimum amount of information to CMS. For example, a single quality measure, attesting to 1 improvement activity, the base score for ACI, which I'll explain in just a bit. If you do that minimal amount of information, you are in this submit something. You could literally put 1 G code on 1 claim sometime in this calendar year, and that would be enough to get you a score on 1 quality measure, and that would cause you to avoid that 4% payment penalty. So a few minutes of work, and you can at least get into the submit something bucket. I urge everybody to push for at least categories 3 and 4, however, and that is fully participating in the program. The only difference really between the 3rd and 4th categories here on this slide is the amount of data that you're submitting. Under submit for a partial year, you are submitting data for a minimum 90-day period across the performance categories. You can maximize the financial potential of this program under the 3rd option here, under partial. The only difference with submitting for a full year, category 4, is that you are submitting data, full 365 days of data across all the performance categories. So again, between the 3rd and 4th option, which I hope the vast majority, if not all, providers are going to be shooting for, you can realize the full financial impact of the program. It just depends on the amount of data that you submit and the performance results. There's a lot of different ways to get the data to CMS. Their options are a little bit different between individual and group, as is shown on this slide. The data submission option, and you'll hear me bring this up a few more times throughout this, the data submission option matters significantly under the quality category. And I'll talk about that as we get a little bit deeper on why that is. But data submission option matters significantly for quality. It is one of the most important decisions to be made in this program, for this year anyway. But there are a lot of different ways. You can connect to a qualified clinical data registry, qualified registry. You can send in data direct from your EHR if your vendor offers that. Claims-based reporting is an option under quality for individuals. There is an attestation website coming that will allow you to attest to the improvement activities and the advancing care information. That is not an option for quality, but there is a new web portal coming. It is not released yet. CMS should be releasing information on that relatively soon, but there will be a place that you can just log in and attest for free under the improvement activities in the advancing care information category as well. If you're unfamiliar with what some of those data submission options are, we've got little definitions for them here. I'm not going to go through them. It's just more for your reference. So what does it mean on the MIPS track then, and those incentives and penalties? What does it all mean if you participate? As was the case under some of those legacy programs, Meaningful Use and PQRS, there's always a 2-year lag between the performance year and the payment year. So the payment adjustments will be applied for the 2017 performance year. They'll go into effect for 2019. Similarly, as we saw under Meaningful Use and PQRS. This program is also budget neutral. So those that are getting penalized are paying for those that are getting incentivized. It's a linear adjustment based on that final MIPS score as compared to the set performance threshold for that year. So there is, for the first year, looking at that MIPS final score, you need to get over a whopping 3 points. If you get 3 out of 100, that will negate that payment penalty for you. Anything over 3 points puts you into the positive side of the adjustments. You want to get as close to 100 as you can. But unlike, let's say, under Meaningful Use, where the adjustment was the adjustment, the incentive was the incentive, the penalty was the penalty, this is a linear adjustment. So you could be anywhere between the positive and negative 4%. Those scoring in the bottom 25% will automatically be adjusted down to that maximum penalty for the program year. So in year 1, that maximum penalty is 4%. So if you find yourself in the bottom 25% of total participants, you will automatically receive that full 4%. You could be elsewhere in the negative adjustment too, but if you're in that bottom quartile, you will absolutely get 4%. So higher scores then receive proportionally higher incentive payments up to 3 times that maximum payment adjustment for the year. That we really won't see that 3 times modifier, as it's called. We probably won't see that in use in this first year of the program. We should see that realized in future years. But because of this budget neutrality that they've built in, along with the pick your pace options that are going to make it relatively easy for providers to not get penalized at all, that means that there's not going to be a big pool of money on the penalty side to divide out amongst those that are performing on the positive side. So they've got this 3 times modifier built in just to maintain that budget neutrality. We'll see it, I think, in use in future years, probably not in this first year, but that what would have been a 4% gain this year could have been modified 3 times over to get all the way to 12%. There's also something called the exceptional performance bonus that's built in. So the program is budget neutral for the most part. There is an additional $500 million a year that's being set aside for exceptional performers. So anyone that is in the top quartile, some of those best performers in the program, are going to have some additional monies that will get divided. We could see as much as another 10% bump in Medicare reimbursements for that top quartile. So working in that 3 times modifier and that additional 10%, as we get deeper into this program, as of 2024, we could see providers receiving upwards of a 37% increase on their Medicare reimbursement rates, which is significant. I want to be one of those offices. So this kind of wraps up those incentives and penalties, puts a graph over a lot of what I just talked about. In the middle dashed line between the green and the red boxes, we've got that performance threshold. That performance threshold is going to shift every year. In the first year, it is a whopping 3 points. CMS really couldn't have made it any easier to avoid that payment penalty. In future years, we will see that threshold move. Next year, it's proposed to be, I think, 13 points. After that, it is designed to be the average or the mean score of all the prior participants in the previous year. So as you can imagine, as people get better and better in this program, it's going to continue to drive that performance threshold up. And you will have to continually do better than the provider sitting next to you in order to maintain your Medicare reimbursements. So we will at some point see a majority of half the providers on the plus side on this, but we're going to see half the providers on the downside of this as well. You don't want to be one of those folks. So performance threshold in the middle, anyone that's below that threshold will get penalized. If you're in that lowest 25%, you're going to hit the maximum penalty for that year. Anyone above that performance threshold will see a positive gain, a positive adjustment on their Medicare reimbursements. And then anyone that's in that top quartile gets into that exceptional performance bonus. And so you get to divide out that additional $500 million that's available each year as well. So we'll take a brief look at the other side then, the track 2 of the QPP, the alternative payment models or advanced APMs. So what are APMs? Well, it's a generic term that describes a payment model in which providers take responsibility for cost and quality performance and have their payments adjusted as a result of that. So it is about pushing risk back on the providers so that if they're not providing low-cost, high-quality care, their payments are docked for that. So according to MACRA, APMs in general include all 3 tracks of the Medicare Shared Savings Program, the MSSP ACOs, so tracks 1, 2, and 3, those are all APMs. Demonstrations under the Healthcare Quality Demonstration Program, the CMS Innovation Center models that are out there, other demonstrations required by federal law. So MACRA doesn't change how any particular APM pays for medical care and rewards that value. It's gonna build on top of that. So these APMs that are out there, ACOs, you've got some sort of shared savings, you've got some sort of contract that's built with that alternative payment model. That stays in place. Nothing changes in terms of that contract with that entity. MACRA or the QPP builds on top of that. It adds additional incentives on top of that model. And MIPS APM participants, as I mentioned, if you recall in that conceptual diagram, we talked about MIPS APMs kind of bridging the gap between the 2 tracks, between the MIPS track and the alternative payment model track. MIPS APMs then, as part of that bridging the gap, they still have to participate in MIPS, but they receive favorable scoring under some of the MIPS performance categories. So if you find yourself bridging the gap where you're in an ACO, but it's not an advanced APM, you still get some really great scoring. So as I kind of alluded to then, some APMs are deemed advanced APMs, and that's really what we're shooting for here. That's the gold standard that eventually we want to see the majority of QPP participants in these advanced APMs. Well, what are those? I'm actually going to start at the bottom of this pyramid here with the MIPS APMs, and I'll kind of work our way up to the top. So MIPS APMs, again, that's bridging the gap. You're in an ACO, but there's not enough risk built into it, so it doesn't qualify as an advanced APM. It's going to be a MIPS APM. For instance, Track 1 MSSP ACOs, so all of the Track 1 ACOs, that is by far the majority of the Medicare ACOs that are out there. I think it's close to 90% of the Medicare ACOs. Those are Track 1 ACOs, and those qualify as MIPS APMs. So those participants still have to participate in MIPS. They're going to participate at the group level under that APM entity, under that MIPS APM or that Track 1 ACO. So they still have to participate in MIPS, but they get some of that really great favorable scoring in the program. In the middle, we've got qualified medical homes. It's a medical home model that's expanded under CMS authority. They have a different risk structure, but if there's enough risk built in, it will qualify as an advanced APM. We really only have CPC Plus as an option, and I know I don't think even all of the states that are on today's call are CPC Plus states, but Michigan is, which is where I'm talking to you from. So CPC Plus is a advanced APM, as it is a qualified medical home. Then lastly, we've got these advanced APMs. That's a term that's been established by CMS. It really comes down to the amount of risk that's pushed back on the providers. If there is a roughly 8% risk pushed back on the providers for those shared savings models, then that APM can reach advanced APM status. So for the most part, it's about having enough risk built into it. And if it does, it's an advanced APM. They have the greatest risk, of course, but then they also offer the greatest potential for rewards. So looking at the incentives then for the advanced APM, as I mentioned, the model design stays in place. So whatever contract you have with your track 2 or track 3 MSSP ACO, your next generation ACO, those are all advanced APMs. Whatever model you already have, that stays in place. Those flexible payment bundles, shared savings, whatever features, those stay in place. Not affected in any way, shape, or form by the QPP. The QPP then builds on top of that. It adds this 5% lump sum bonus payment if you are significantly participating in that advanced APM. So I'll talk about the 5% lump sum bonus first, and then I'll explain briefly what I mean by significantly participating. So the way that 5% lump sum bonus works is if you qualify during 2017, this is our performance year, 2018 is then the measurement year for your bonus. So throughout 2018, CMS will take a look at your Medicare Part B reimbursements for that calendar year of 2018, and then in early 2019, you get an additional 5% lump sum bonus based on those 2018 Medicare charges. Does that make sense? That's how that 5% lump sum bonus works. So what I mean by significantly participating is it's not enough to be in an advanced APM. CMS has attributed their beneficiaries to the different advanced APMs in the area. You need to ensure, or the ACO needs to ensure, that a certain percentage of those patients are seeking care from members of that ACO. It's kind of back to the managed care sort of program, where you have to make sure that those patients are seeking care from the providers that you want them to. If you reach that goal, it is about 25% in this first year. We're going to see that percentage increase over time. Then if that minimum 25% of charges are being passed through that advanced APM, then you reach something called QP, or qualified participant status. It's not really a factor for this year. CMS, looking at all the advanced APMs, they let us know, I think a month or two ago, that all of the advanced APMs out there are on track to reach QP status. So not really a factor in this first year. If you're in an advanced APM, it's almost guaranteed that you have reached qualified participant status, which means you will get that 5% lump sum bonus. I think QP status will be a factor as we get deeper into the program in future years, because the threshold for QP status is going to increase significantly over time. So it will eventually be more difficult to reach QP status. But for now, in this first year, CMS tells us everyone is good. So another one of the incentives then is the higher reimbursement updates. So in a few years, the physician fee schedule, the standard rate, is going to lock in place. And the only way to get it to move is to participate in the quality payment program. Starting in 2026, we will start to see that Medicare fee schedule start to tick up a little bit again each year, and it's going to tick up at 2 different rates. So for those that are in an advanced APM, it's going to be higher. It's going to tick up at 0.75% per year. For everybody else, the MIPS participants, it's going to be at 0.25%. So an additional incentive for being in that advanced APM is you get better and better annual Medicare reimbursement rates. And you are also exempt from the MIPS program, as I mentioned earlier on too. So under those different exemptions, if you're a qualified participant in that advanced APM, you do not have to participate in the MIPS track. There's not a lot of advanced APM options out there. We will see this list expand over time. We have the comprehensive ESRD care model, CPC Plus, as I mentioned. The MSSP tracks 2 and 3 are all advanced APMs. Next generation ACO models are advanced APMs, and the oncology care track 2 is also. And again, we'll see this list expand over time. If you're curious to see if your APM is an advanced APM, you can go to the QPP.cms.gov website. They are continuously updating that list as additional advanced APMs are named. So this kind of wraps up the timeline, summarizes a lot of what we've been talking about here. So we see that fee schedule at the top. It's going to continue to tick up by 0.5% for a few more years. As of 2020, it's going to lock in place for 6 years. And then in 2026, it will start to move up again at 2 different rates, depending on whether you are in an advanced APM or if you're a MIPS provider. We've got that MIPS track in the middle. We've got 4 performance categories. In this first year, we're only going to use one of them. Or I'm sorry, we're not going to use one of them. We're not going to use the resource use or cost category. You will have to participate in the other 3. We'll see the plus and minus percentage for your Medicare reimbursements will start out being at 4%. The next year, it bumps up to 5%. Following year 7%, and then it tops out at 9% in the fourth year, and that will continue indefinitely. And then at the bottom, we've got the APM track. We get that 5% lump sum bonus if you're a qualifying APM participant, if you've reached that QP status, and then you are excluded from MIPS. All right, so now what? Now that you have an idea of what this QPP program is, like how do you participate in the MIPS track of it? There is a lot of questions. There's a lot of work to be done. There's a lot of confusion out there. So I'm going to hopefully dispel some of the rumors out there and hopefully set you on the right track for where you should be focusing your time and attention. There's several steps here. I'm going to dive deeper into each one of these in just a moment. But from a high level anyway, you're going to determine that eligibility and understand the requirements. You're going to choose whether you're going to participate at the group level or at the individual level. You're going to choose your submission methods and verify those capabilities. You got to verify with your EHR vendor in the registry, if you're working with one, that they're ready, that everything is all set there. You're going to prepare to participate by reviewing your practice readiness, the ability you have to report on these measures, and then the pick your pace options. Choosing the measures is a vital step, of course. There's 2 different resources you can use there, the QPP.cms.gov that I've already talked about, and then our resource center. There's a great web portal, the QPPresourcecenter.com. I suggest you go to that one as well and sign up for some valuable measure selection resources. There's a lot of helpful tools there. You're going to verify the information you need to report successfully, care for those patients, record the data the way that you're supposed to. It's a very important part, especially on those quality measures. And then in the beginning of next year, the first quarter of next year is when you're going to be submitting that data to CMS. I'm going to dive in a little deeper into all of these, kind of one at a time. First one is determining your eligibility. So it's a few different ways to do this. Honestly, the one at the bottom is your best one. You could calculate your annual patient count and your billing amounts for this 2017 transition year. I got some information from here on how CMS did it. If you overcome that low volume threshold, meaning you provided care or to more than 100 Medicare patients and you've billed more than 30,000 in Medicare Part B, if both of those conditions are true for you, then the answer is yes, and you're eligible and you need to participate in order to protect your reimbursement rates. If it's no, then you're exempt and you don't have to participate in this year. CMS sent some letters earlier this year. I'm not sure that went very well. A lot of those letters didn't make it to the people that needed them. They got lost. We don't know where a lot of them went. But you may have received a letter from CMS that helped to give you some information on your clinicians, on whether they are MIPS providers or not. What I suggest is going to, what the third bullet shows here, going to qpp.cms.gov. Right on the main home page, right at the top, there is an eligibility check. Go there, put in your individual NPIs one at a time, and it will tell you if the providers are MIPS providers for your organization. The other great thing about going to this site is the special status information. So there's a lot I can't get to in this webinar in terms of hospital-based providers, non-patient facing providers. There's some special statuses that if you're a part of those, if you reach the goal of the special status, it might provide some flexibility for the program. For instance, hospital-based providers don't participate in the ACI track. And so some of that special status information can be picked up from the CMS.gov website. Those letters that you got earlier in this year would not have given that special status information. So you may need to go to that special status, to that website to get that special status information to figure out kind of how your providers need to participate in this first year. Submitting as an individual or as a group, I think, is one of the most important decisions to be made. This is not an easy one to figure out. Honestly, I don't think you really can determine which one of those is the best option until you get the data and really crunch those numbers. And I'll talk about why that is. So there's a lot of factors that need to be considered when you make this determination. Your TIN structure. I think payer mix is probably one of the best factors that you need to take into account. So follow me along here. If you have a practice with 5 providers and 2 of them are carrying the majority of your Medicare Part B volume, the other 3 just have a little bit of Medicare. If your top 2 providers that are also carrying, they're carrying the most Medicare volume are also the best MIPS, they're scoring the best in this, you might want to stay and report as individuals because you want your 2 best performers who are also carrying the majority of your Medicare volume to get the biggest reimbursement bump possible. And you could do that by allowing them to individually report, meaning just their score is a factor, so those high performers get the biggest reimbursement bump. Conversely, if it's the other way around, if those 2 providers that are also carrying the majority of your Medicare volume are scoring lower in terms of MIPS, group reporting could make a great deal of difference. That could be the right decision to be made because your low performers that carry the most Medicare volume will have their rate brought up. They'll have their MIPS score increased by the other 3 by group reporting, and you add those numerators and denominators together. So payer mix alone could help you decide whether group or individual is the right way to go. No easy answer here. You could look at technology available. Are you part of a multi-specialty group? In which case, group reporting probably isn't the best way to go because if you group report, everybody is reporting on the same quality measures. And if you're part of a multi-specialty group, those 6 quality measures are most likely not going to apply to all of the multi-specialties, in which case individual reporting might make more sense because you can get better quality scores at the individual level. Past performance and legacy programs, you could pull some past information that could help you decide how to report as well. There's a lot of factors that go into play on group versus individual. There's no easy way. There's no blanket answer here. You just got to crunch those numbers and figure out which way is going to net the biggest financial gain for the practice. Whichever that is, choose that. Do not choose group versus individual based solely off of it being easier to report as a group. I think that would be the worst decision you could make. Pick the submission method that is going to net you that best MIPS score collectively, or is going to net the biggest gain financially. Choosing your submission method, second most important decision. Cannot stress this one enough, and I'll explain why when it comes down to quality reporting. So in terms of submission methods, I talked about earlier how there's a lot of different ways to get that data to CMS. Under the quality category, the way that you are scored is you pick your quality measure, and you are scored on that quality measure based off of a baseline, off of a benchmark for that quality measure. So depending on how you compare to prior performance under that quality measure, you're going to get a score anywhere from 3 points to 10 points for that quality measure. There are different benchmarks for each submission method. So if you are submitting via EHR, if you're submitting via claims, if you're submitting via a registry, be the CMS web interface for larger groups. There is a separate benchmark that has been developed for each one of those submission methods. So what that means is the exact same quality score could net different points just based off that submission method. And we see a wide variation here. There are examples where a particular score, as it's compared against those benchmarks, could net you 4 points under one submission method or 8 points under another submission method. So the quality of care is exactly the same. You have done nothing different in terms of patient care, but just by routing that data to CMS via a different route could net you a significant difference in your quality score. And with quality being worth at least 60% of your score, it's going to matter. We could see a massive difference in that quality score. It could ultimately mean the difference between a positive adjustment and negative adjustment in this program as we get deeper into future years of this program, when that performance threshold is higher than a whopping 3 points. I think we will see that submission method making all the difference. It could make or break that final score. So this is a vital, I cannot stress enough, decision to be made, is how are you going to get your quality data to CMS? Pick whichever method that you're capable of doing, but also, if you can, choose the one that's going to net you that best quality score. You could speak with your specialty society, if you're a member of. Some of them are offering different registries that can consolidate and can report on, can be a submission option for you. You consider there are some different technical assistance programs out there that can help you decide, including ours, the QPP SIRS program, again at QPPresourcecenter.com. Highly recommend you signing up for us there. You can also go to the qpp.cms.gov website. There's a lot of great information and support options available there to help you choose that submission option. But vital. Preparing to participate, you're going to consider your practice readiness. Have you previously participated in quality reporting programs such as the PQRS program? You can pull some prior data to kind of help you, kind of guide you and give you some additional information. Evaluate your ability to report. What is your data submission method? Are you prepared to begin reporting data for that first quarter of next year? To pick your PACE options, and you decide that now. Don't pick option 1, which I don't even have listed here, which is the do nothing. Hopefully a small subset of providers pick that first one listed here, the test only. It's easy to get to that one. But hopefully everyone will go into at least partial or full year, but you're going to want to decide that early. I would say shoot for partial or full year, knowing that you can always fall back on the test option to at least avoid that 4% penalty. But there's a lot of money to be had here, and we've got that time to kind of test the system. Now's the time to kind of shoot for the moon, fully participate if you can. That's why CMS gave us these pick your PACE options. It's an easier way you can kind of test your systems and make sure that they're working properly, so that next year when we don't have these pick your PACE options, you're ready. You're ready to hit the ground running and you can perform well in 2018. Choosing your measures and activities, also a vital decision. I would say these are the top 3 decisions to be made. Is that group versus individual, your submission options for quality, and then picking those quality measures as well. There's a lot of resources available to you to help guide you in that measure selection. Again, you can go to the CMS QPP website. I would urge you to sign up for ours. It is completely free for practices of 15 or fewer clinicians. CMS is allowing us to kind of build on what they've done under the qpp.cms.gov website. We can assist you, we can guide you, we can assist you with project plans based on your specific goals for the program. We can feed you very specific bite-sized information. It gives you a team of experts that you can bounce questions off of. So I highly recommend that QPPresourcecenter.com. But if you go to the CMS website, you can click on the Explore Measures tab, select your performance category, and then review all the information that's there to help you choose your quality measures, understanding what the ACI measures are, and then choosing those improvement activities as well. Some tips for selecting those measures and activities. As much as you can, you should be kind of looking at the practice improvement goals, looking at your patient population, the clinical conditions that you treat, and really in trying to choose the measures that make the most sense for your scope of practice. Don't report just to report. Report on measures and activities that make sense to you. You want to look at the quality data that you might be submitting to other payers. As much as you can, I would advise you to try and get 2 birds with 1 stone in terms of quality measure selection. If you are already reporting under other value-based reimbursement programs, and you can consolidate and ensure that that the measures that you're reporting on can be used across multiple programs, it's going to reduce your reporting burden. You could look at some of the legacy quality programs at the information coming out of those programs still. Last Monday, the most recent QRUR, or Quality Resource and Use Reports, came out. That is for the 2016, I think, or maybe 2015 PQRS program. You can get those quality reports, and it's going to guide you. It's going to give you some additional information on how your providers are doing. It won't be a factor until we start using the cost category, but those reports provide some of that cost category information. So again, you can see how your providers are doing, so that when the cost category is used in future years, you can just kind of see how they're doing. It can guide you. Verify that information that you need to report successfully. Really can't stress this one enough too. We see a wide variety of issues with quality reports. There are a slew of vendor errors that you don't know about. There are codes that are not mapped correctly in the back end. Just you name it. We see a wide variety of issues. And so these kind of almost administrative or setup issues could be significantly affecting your quality scores. So you might be providing, your providers are doing exactly what they're supposed to be doing, following the standard of care. They're providing fantastic quality care to their patients, but because something isn't mapped right, or there's some radio button that's not being used, or structured data is not being recorded in just the right place that your EHR is looking for to calculate that quality measure, it could break that quality measure for you, where it's not calculating appropriately. So you really need to verify that information, especially when it comes to those quality measures. Run those reports right now for those measures that you want to report on, and look at who's in that denominator, and look for those that are missing in that numerator, and find out why. Why aren't they in your numerator? It could be that the provider is just not doing what they were supposed to do. They didn't order the test they were supposed to, or whatever it is. But I think a lot of you are going to find that it's really an administrative thing. There's some sort of workflow that's causing these patients to not be in the numerator. And you could just tweak something. You could map a code in the back end. You could talk with the provider and say, hey, can you make sure that when you do this, you're clicking right here, clicking this radio button, clicking that chat box. Don't dictate something into a progress note. Record that information here where the EHR expects that data to be. Just doing that could significantly boost those quality measures. It would be a shame to get a low quality score when the work is being done and it's just not recorded properly in the EHR. So do your due diligence now to ensure that those measures are calculating the way that they're supposed to. And there's, again, no easy way to do it. You just got to dive into the work and start looking at those quality measures and ensuring that you are getting all the numerators you possibly can. You can also get measure specifications for once you choose your quality measures. You can work with us at the QPP Resource Center. You can also go to the qpp.cms.gov site, and you can download the what's called the quality measures specification files for each one of those quality measures. It gives you a wealth of information on what that quality measure is measuring and how it measures it. Very specific information on codes, so that you know exactly what that quality measure is trying to measure, so that, again, you can ensure that your system is working properly. Submitting your data, you're going to care for those patients and record that data. You want to submit that data to CMS prior to the March 31st, 2018 deadline. So the window is going to open on January 1st. You'll have those full 3 months to get that data in. Encouraged us to submit early. And this is something else, little tip, cannot stress this enough. If you are relying on somebody else to submit data on your behalf, don't trust them to do it. get proof that it was done. There's a lot of humans involved, and we all make mistakes. By no fault of their own, we can't fault that we're human, but we all make mistakes. And again, it would be terrible to see providers getting a 4% penalty on their Medicare reimbursements simply because somebody forgot to click a button. So ensure that that data makes it to CMS during the data submission window early next year. Seek that confirmation. Some concluding thoughts before I get to some questions. We are in the beginning stages of long overdue payment reform. I guarantee that we are going to see the QPP evolve over time, just like we saw meaningful use change year after year after year and just get better and better or get fine-tuned. Most definitely, we're going to see the same thing with the QPP. That long-term goal is to eventually push as many providers into advanced APMs. So for now, the majority of participants are going to be in the MIPS track with a small subset in the advanced APM track. Eventually, CMS wants the scale to tip the other way, where the majority of providers are participating in the advanced APMs instead, and a fewer number of them in the MIPS track. There is significant money to be had here. MIPS bonuses are significant for those high performers. We could see, as I mentioned earlier, that 37% bump in their Medicare reimbursements on the top end. You look at the downside, significant penalties coming at providers. With that, it's going to max out at 9% payment penalty. So we could see, as we get future into this program, a 46% difference between the reimbursement rates of the lowest performers and the highest performers. That is going to make or break a practice. I don't know how a practice could survive if the practice down the street is getting 46% more for their Medicare Part B reimbursements than they are. Also, don't forget about the current rules that are still in place. We're still, while those legacy programs are kind of trailing off, we still have payment penalties and whatnot that are coming at providers. Those all sunset at the end of next year, December of 2018. All those penalties and incentives for the previous legacy programs fade away. And then in 2019 is when we'll start to see the financial impact of the QPP in people's practices. Got a bunch of resources here. The top two I've talked about over and over again already. Our website, the QPP Resource Center for the Midwest. I highly recommend, again, it's a free website. It cannot hurt. It can only help to join us here. We're going to help guide you, provide some additional resources. We have taken the wealth of information at that second website, the qpp.cms.gov site, and help to kind of break it up into bite-sized chunks. We can help you with the needle in a haystack. If you just have a specific question, we can give you a resource to back up and answer that very specific question versus going to a CMS site and hoping to find it there. Again, there's great information there. You pair those two together, and I know you're going to get all the information you could possibly need on the QPP. Additional resources as well. And with that, I'm going to open it up to questions. I've had a slew of questions come in already. If you have any additional questions for me, please go ahead and put them in. I will answer some of these questions now as I have time, or have answers. If I run out of time, or if I just don't have the answer, just note that I will get to your question. You will receive an email directly from me following the webcast. Okay, let's take a look at what we've got. Looks like some people may have had a connection issue. Some people had an echo. Hopefully that wasn't the case. I had others saying that they don't have an echo, so I'm not sure what caused that. I apologize if it has been difficult to understand me. This is our first time doing an actual webcast, so there might be issues with no idea what caused that echo. For the low volume threshold, the final rule has not been released that it may go to 200 patients and 90,000, right? So that's for 2018. So the low volume threshold is established for this first program year. For 2017, it is as I had it on that slide. That has been finalized. It is $30,000 in Medicare Part B allowable charges and 100 patients. They are proposing that low volume threshold to go up significantly for next year, but that is for the 2018 program year. That does not affect us this year at all. But for 2018, It is proposed to increase to 90,000 in charges and 200 patients. So what that means is providers that are MIPS providers this year, because that low volume threshold is at 30,100, might be exempt next year, may not have to participate next year because we will likely see that low volume threshold get increased to 200 patients and 90,000. But we'll have to wait and see to see how that finalizes. That is not set in stone yet, has not finalized. We expect that final rule that will define the 2018 program year. We expect that to finalize later this year, probably October, November, but we'll have to wait and see what that low volume threshold is. Our office created a whole new business with a new tax ID beginning on May 15, 2017. Does this mean we are exempt for 2017? No. Being a new tax ID doesn't mean that your providers are not MIPS providers. It comes down to those individual providers and when they became credentialed with Medicare. But the fact that you're a new tax ID this year doesn't mean your providers are exempt from MIPS. On slide 13, can you explain the phase 2 dates for review? Could that review of those late dates change a clinician's eligibility for 2017? That is a great question. So I had two different dates. I'm going to get back to my slide. Let's bump to slide 13 real quick. So there's two different measurement dates that are going to be used here. The first one already passed. If I can somewhat quickly move up here. Okay, slide 13. See those dates used at the bottom. So we have phase 1 that was September 1st of 2015 through August 31st of 2016. So they have looked at all the providers and compared them against that low volume threshold, and they have anyone in that first phase who was exempt is going to be exempt. It doesn't matter what happens in phase 2. They're using a second measurement phase to measure providers that they didn't have enough data on in that first phase. So if you've got that determination based off of phase 1, CMS determined that you are exempt from MIPS, then you're going to be exempt from MIPS. You're not going to now all of a sudden be a MIPS provider during that second phase. They're going to use phase 2 if they just didn't have enough data during phase 1 to make that determination. So it's not going to cause anyone that was exempt to suddenly be a MIPS provider, and it's not going to cause anyone who was a MIPS provider to suddenly be exempt. They're just using phase 2 for anyone that they did not get additional information on. Can you explain the 3 points again? Sure. So the 3 points is your performance threshold for 2017. So that's the mark that that's the bar you have to get over to avoid a payment penalty. That performance threshold is going to shift every year. For the first 2 years, CMS sets that threshold for us. In 2017, it is 3 points. In 2018, it is proposed to be 13 points. I don't know what it's going to be. We'll wait to see how that finalizes later this year. After that, it is going to be the mean or median, the average score from the prior performance across all MIPS providers. So that 3 points, that performance threshold is in relation to your MIPS final score. You've got your 3 performance categories that we're using each year. They're weighted differently. Quality is worth 60% of that final score. ACI is worth 25%. IA, your improvement activities, are worth 15%. So you perform under each one of those performance categories, and it's going to net you a certain number of points. All of those points add up to that MIPS final score. It can be anywhere from 0 to 100 points. In this first year, with that performance threshold being 3, anyone who scores 3 points or more is going to at least negate that payment penalty. As you get further and further above 3, you could see a positive Medicare adjustment. Anyone scoring below 3 points is going to see that negative. So I hope that explains what the 3 points is. But you want to get at least 3 points. And that's where that the test-only option under the pick your pace comes in, is that by giving that minimal amount of information, it's going to give you some minimal points. So that's why one G code on one claim sometime in 2017 gets you on the board for quality reporting. The lowest number of points you can get under any quality measure is 3 points. If to get any, you're either going to get 3 or you're going to get anywhere from 3 to 10 points when you attest to a particular quality measure. Lowest is 3. So that's why giving that minimal amount of information can negate that payment penalty under the test option, because it's going to, giving one G code on one claim is going to net you at least those 3 points. So again, low bar. CMS really couldn't have made it any easier to avoid the payment penalty in this first year. If we do minimum data submissions, I thought there was no penalty under Pick Your Pace. However, the slide states that the bottom 25% will automatically receive the 4% penalty. Please explain if we do or do not get penalized. That's a really astute question. Thank you for bringing that up. So yes, it's in future years that bottom quartile will automatically be assessed at the bottom. Because of the Pick Your Pace options, it's really just the do nothings, the people that decide to submit nothing at all, that are going to get hit with that payment penalty. And that could be the bottom quartile. Hopefully not. Hopefully everybody else chooses to at least do that test only. So you're right. That it's in future years when we're not in these Pick Your Pace options, that bottom quartile will be assessed that maximum penalty. In this first year, if you get 3 points, you're not going to get penalized. Doesn't matter if that puts you in that bottom quartile. If you get 3 points, you're over that performance threshold, you will not be penalized. Anything below 3 points, you will get penalized. But really, if you do anything in the program, you're going to get at least 3 points. So it's really just those that choose to do nothing at all that will get a goose egg, they get a 0 on their MIPS final score, that are going to get that 4% penalty in this first year. Next question says, I didn't think track 1 was an APM. Is it now? So don't get confused between APM and advanced APM. So APM, that's a very generic term. So alternative payment model, or APM, encompasses all of the ACOs out there. Every ACO that's out there is some type of APM. So track 1 MSSPs, which again is like 90% of the Medicare ACOs that are out there, track 1 ACOs are APMs, but they're MIPS APMs. They are not advanced APMs. Track 1 does not have enough risk built into that model to become an advanced APM. So as a track 1 ACO participant, you are in a MIPS APM. You are bridging the gap between the two paths of the QPP. You are a MIPS provider. You need to participate in MIPS to protect your Medicare reimbursement rates, but you are in an ACO. It just doesn't qualify. There's not enough risk built in. There's a track 1 plus that is coming live in 2018. So a lot of the track 1 ACOs that are out there are right now trying to change their model to build in more risk and become a track 1 plus. They reach that track 1 plus status, that will be an advanced APM. But as it stands right now, track 1 is a MIPS APM, but not an advanced APM. Let's see, next question. Do CPC Plus practices have to report for ACI? There's a lot of confusion around CPC Plus providers and how they have to participate. I believe that they do. I think they're, especially if you're also in an ACO, if you're in a track 1 ACO and in CPC Plus, that makes it a big mess. But as best I know anyway, these CPC Plus providers still have to do some reporting. The payment structure doesn't come at them the same way, but I think to be safe at this time anyway, you should plan to participate fully, even as a CPC Plus. Again, we're really trying to figure out how CPC Plus model as a medical home, how that plays within the program and how that, and again, we're still gathering some information on that. I think it would be safe to assume that you're gonna submit anyway. It would be safest to do so, even if it's not needed. And again, as we work to find out additional information about how these programs work with each other. Is the QPP website up to date at this time? We were told by a high-level staff member at the QPP that it would not be updated until October. So it is up to date. We are expecting a very significant update in terms of quality benchmarks coming very soon. There are 271 quality measures to choose from. Some of them don't have benchmarks right now, or they're stratified and we just don't have enough information on how those benchmarks really play with in terms of stratification. We are expecting a significant update coming in, hopefully in October, that will give us additional information on quality benchmarks. So that is probably what this high-level person was talking about, but they are continually updating the QPP website. If you look, especially if you get to the resource library, you can see the date that they've been pushing additional information there. CMS is doing a great job of keeping that up to date and providing additional resources. They continually add more and more resources to that site, but it is true that we are expecting a significant update of additional information, especially when it comes to the quality benchmarks in October. I am getting very close to my 1:15 cutoff, and I have a lot more questions. I will see about getting one or two more in, and then, as I mentioned, if I don't get your question during this broadcast, I will email you directly as well. I have a new provider, new to our practice, and checking the EC eligibility shows him as eligible under his previous practice. Does this mean he is eligible under our practice? So yeah, if a provider is just coming to you and they're being deemed a MIPS provider, if they're new to you, you need them to participate. You need to look at whether they overcame that low volume threshold in that measurement period. And if they're new to you this year, you need them to participate in MIPS to protect those reimbursements 2 years from now. This is an interesting thing I think we'll see over time is the MIPS score is going to follow the clinician wherever they go. So if they choose to not participate this year and don't get a MIPS score, and then 2 years from now they are working for a different provider, that negative penalty from 2017 from not participating with their previous employer is going to follow them to their new employer. If a clinician is working at multiple, under multiple TINs this year, so which of course happens a lot, if they are working for a new employer 2 years from now in 2019, that best MIPS score is going to follow them. So if they get an 80 at one employer and a 40 at another employer this year, in this first performance year, in 2019, if they're at a new employer, they're working for a new TIN, that 80 score is what's going to follow them. So what I think is interesting is we'll probably start to see, or we should start to see MIPS final scores on provider CVs, because it should be part of that hiring decision, that hiring decision is if you've got two providers that you're looking to hire and all other things being equal, you want the one with the higher MIPS score from 2 years ago to follow, to be the one that works for you, because that score is going to follow you. You don't want a provider bringing with them a negative payment penalty into your TIN. So I think we'll start to see MIPS final scores be on CVs, and it should be a question that you're asking after this performance year. If you're hiring somebody next year, you most definitely want to know what their MIPS score was for 2017, because that score is going to follow them to your organization. All right, folks, we are at 1:15 and I have to log off. I apologize for not being able to get to all of the questions. Some really great questions came in. I'm looking forward to answering all the rest of them as well. Thank you so much for participating in our webcast. Hopefully you got some great information, and we look forward to seeing you again in our future webcasts. Thank you all for joining, and have a great day.